After a stroke, one of the most misunderstood treatment is Botox. When people hear this name, the first thing that comes to their mind is celebrities, wrinkles, beauty clinics, etc. But in the world of neurology and rehabilitation, this same Botox has become a life-changing treatment, helping millions of stroke survivors get back their movement and independence. In today's video, we will explore this topic in depth: how Botox works after a stroke, what the science says, which major research studies support it, and what is the dosage and safety guidelines, and most importantly, when this treatment is effective and when it absolutely should not be used. Okay, so this video will be long, but if you are someone who is going through the stroke recovery, this information can change your decisions. And let's start with the basics only. So, what is stroke? It's a condition where blood supply to some part of the brain gets cut off, either due to a clot or due to bleeding. When brain cells don't get oxygen, those cells are get damaged or die. If the part of the brain that contains movement gets affected, the opposite side of the body becomes weak or paralyzed. This is called hemiplegia. Okay, so but here is an interesting and counter initiative thing. Most people think that after a stroke, muscles become weak and loose. In the initial phase, this is true. It's called flaccid stage, but after a few weeks or months, an opposite phenomena happens. Okay, so despite being weak, the muscles become overactive. They start tightening on their own, contracting on their own, and the patient's control over them decreases. This condition is called spasticity. To understand spasticity, let's use a simple analogy. Imagine a car where both the accelerator and brake system are damaged. Okay, so normally when you move a muscle, the brain coordinates the accelerator and brake together. Some muscles contract, some relax, so the movement is smooth. After a stroke, this coordination system, which exists between the brain and spinal cord, gets disturbed. The result is that muscles behave like a stuck accelerator. They continuously receive a signal to contract, whether the patient wants to do something or not. Okay, so this is the basic idea. So where is this spasticity most commonly seen? In the upper limb, the elbow flexors, meaning the biceps, which keep the arm bent, the wrist and fingers flexors, which make the hand close in a tight fist, the shoulders internal rotation, which pull the arm close to the body. In the lower limb, the ankles plantar flexors, the calf muscles, which point the foot downward and cause walking problems when we call an equinus gait, and the knee extensors or flexors, which further affect the walking pattern. So now here is the problem. Spasticity isn't just an inconvenience. If left untreated, it starts a chain reaction. A tight muscle keeps the joint in a fixed position over a long time. Staying in this position causes the connective tissue around the joint, tendons and ligaments to also shorten. This is called a contracture. Once a contracture develops, it becomes permanent, meaning even relaxing the muscle won't open up the joint anymore. Okay, so because the tissue itself has structurally shrunk. After this stage, surgery becomes necessary. This is why early and effective management of spasticity is critical. This is where Botox comes in. Botox origin is interesting. It's a protein that comes from a bacterium called Clostridium botulinum. The same bacterium is involved in a type of food poisoning called botulism. But medical science learned to purify this same toxin and use it in controlled microdoses that can target specific muscles temporarily. Understanding the mechanism is important. In a body, the signal to contract a muscle comes from a chemical messenger called acetylcholine. This chemical is released from the nerve ending and tells the muscle fiber to contract. Botox blocks this process. It goes inside the nerve ending and stops the release of acetylcholine. The result, that specific muscle where the injection was given temporarily relaxes because it stops receiving the contract signal. This effect isn't permanent. Typically, Botox effect peaks between 2 to 12 weeks and lasts for 3 to 6 months. After that, the nerve endings form new connections and muscle activity gradually returns. This is why Botox is considered a repeat cycle treatment, not one time miracle solution. Okay, now let's talk about the different brands available, because understanding this matters since each brand has different dosing, The FDA has set the ceiling dose for Botox at 400 units for both upper and lower limbs combined, and for Botox at 1000 units for the upper limb and 1500 units for upper limb and lower limb combined. However, an interesting trend has been seen in recent years. Clinicians, based on their medical judgment, sometimes go beyond these label doses, especially in severe spasticity cases, to improve limb posture, make splinting easier, maintain hygiene, and increase passive range of motion. In 2023, a systemic review and meta-analysis was done on lower extremity spasticity, which looked at the two main preparations used, Botox and Dysport. Botox doses range from 100 to 540 units, while Dysport was mainly used at 500,000 1500 unit doses. The most commonly targeted muscles were the calf muscles, the gastrocnemius, soleus, and tibialis posterior, the same muscles that point the ankle downward in spasticity and disrupt normal walking. Okay, an international group of experts formed a consensus panel to evaluate the safety of high dose Botox. They referenced a study where Botox was given rapidly at doses of 500, 1000, or 1500 units over the course of a year. Side effects decreased across cycles, but in two cases, complications like constipation and double vision were seen that might be linked to the toxin spreading beyond the injection site, and 8 patients developed neutralizing antibodies by the end of the study. This is an important point. With repeated high dose injections, the body sometimes builds antibodies that can make future injections less effective. This is why dosing strategy and formulation choice should always go through an experienced specialist. And a 2023 review also highlighted an interesting use case of Botox. A case report showed that it helped reduce spasticity in stroke survivor who, after years of using Botox, had developed antibodies against it. This means that if one formulation stops working, doctors can sometimes switch formulations and still get results. Okay, so now let's move to the research evidence, because this is the most important part. Botox isn't an experimental treatment for stroke spasticity. It has been rigorously tested for decades. First, let's talk about a landmark trial called botulism toxin for the upper limb after a stroke trial. This was published in the journal Stroke, and it helped establish Botox role in managing upper limb spasticity. This trial is still referenced today in newer research papers, including several from 2025. In 2020, another important randomized control trial was conducted across multiple specialized stroke units in the UK. It included patients whose stroke was recent, on average just 18 days prior, and whose arm function was very limited. With a grasp score of 2 or less than the action research arm test, they were randomly split into two groups. One received a placebo and salt water injection, and the other received actual Botox. The result was that spasticity was significantly lower in the treatment group at the elbow from week 2 to week 12, and the wrist from week 2 to week 6, both statistically significant. And the most important finding, contracture formation was lower in the treatment group compared to placebo. Okay, so what does this mean practically? It means that if Botox is given very early after a stroke, even in patients whose arm isn't functionally yet, it can slow down future permanent joint stiffness, meaning contracture. This concept of early intervention is crucial because the time window plays a huge role in rehabilitation. In 2023, Beijing Tintan Hospital, a leading neurology and stroke hospital in China, conducted a randomized trial on lower limb spasticity. 46 patients with a hemiplegic walking pattern were split into two groups. The experimental group received Botox injections guided by electrical stimulation. Researchers used plantar pressure system and gait analysis tools to precisely measure how walking pattern and posture control changed after Botox. This study matters because well-designed clinical trials on lower limb spasticity are fewer compared to upper limb, and this study tried to fill that gap. Now, here is a study every physiotherapist should watch, published in 2024. It shows that Botox alone isn't enough. It included 43 stroke patients whose upper limb spasticity was grade 2 or higher on the MS scale. On one group received only Botox, and other group 21 patients received Botox plus structured stretching exercises. Outcomes were measured before treatment and then At 3 and 6 months, the results showed that patients who did stretching exercises had significantly better modified Ashworth scale score for the elbow, wrist, and fingers at both the 3 and 6 month marks compared to the Botox only group. Okay, so this finding is a game changer, both content wise and clinically, because it scientifically proved that experienced physiotherapists already observed Botox is a gold standard treatment for upper limb spasticity, and its effect lasts 3 to 6 months, but the duration and degree vary patient to patient. To address this variability, adjuvant treatments like stretching are being proposed. So in 2024, another interesting study was also there, combined extracorporeal wave therapy, ESWT, with Botox for post-stroke upper extremity spasticity. This was a randomized control study that looked at what additional benefit comes from adding shockwave therapy after a Botox injection. This trend shows that the research community now sees Botox now as a standalone treatment, but as part of a comprehensive rehab protocol. Okay, so in 2025, the Journal of Neuroengineering and Rehabilitation published another RCT that explored combination therapy, a repetitive facilitative exercises program along with Botox in chronic stroke patients with upper limb spastic paresis. This approach focuses on motor function improvement, not just spasticity reduction. An important distinction: reducing spasticity and improving function are two different outcomes, and both need to be measured. Now let's talk about a big meta-analysis published in the journal Toxins in May 2025. It combined multiple randomized controlled trials to answer a big question: does Botox reduce pain related to post-stroke spasticity, and is there a difference between early treatment versus late treatment? So the background context here is that around 72% of stroke patients develop pain during the disease, and Botox is an established and effective treatment in the subacute and chronic stages of stroke that addresses muscle hypertonicity, disability, and passive limb function. This meta-analysis specifically tries to establish a dose-response relationship, meaning how much dose gives how much pain relief, and whether timing early versus late makes a difference or not. So a 2024 scoping review also mapped out the overall landscape. The authors identified 11 treatment modalities for stroke spasticity, including repetitive peripheral magnetic stimulation, non-invasive brain stimulation, whole body vibration, and Botox injections. This means Botox is a part of larger toolkit, and the best results come when it's combined comprehensively. Okay, so another new development, which is a new formulation, also was tested in a randomized double-blind placebo-controlled trial in 2024-25, especially for upper limb spasticity in stroke or traumatic brain injury patients. This field is constantly evolving with new formulations coming that may potentially offer longer duration or better safety profiles in the future. It's also important to talk about cost, because in countries like India, affordability is a major factor. In 2025, a cost, utility, and a budget impact analysis was done in Thailand to see whether Botox treatment for post-stroke spasticity is cost-effective from a healthcare system perspective. And these studies are important for policymakers and hospitals in deciding how to integrate Botox in standard care. Now let's translate all this research into practical terms. When should Botox be used and when should it not be used? Botox should be used when spasticity is focal, meaning specific identifiable muscles are involved, like biceps flexors or ankle plantar flexors, while the rest of the body is relatively unaffected. When spasticity directly interferes with functional activities, the patient can't open their hand for grooming or drags their foot while walking. Also, when there is spasticity related pain, also when hygiene becomes an issue, like a clenched fist where the nails are cutting into the skin, when the goal in the early stage is contracture prevention as shown in 2020 trial, and most importantly when the patient is ready to commit to a rehab program, because the 2024 study clearly shows that injection alone doesn't give results. Integrating stretching and exercises is as an essential part of the protocol. On the other hand, Botox should be avoided in these situations if the spasticity is so mild that it's actually providing functional benefit. Some patients use their leg spasticity to stand or walk because their muscles are otherwise too weak to support them. In such cases, removing the spasticity could take away their stability. If the spasticity is generalized widespread across the whole body, then oral medications like baclofen baclofen are better suited because Botox only works on localized muscles. If a joint has already developed a fixed contracture, Botox will relax the muscle. But if the tendons and connective tissues have already structurally shortened, the joint still won't regain range of motion. In such cases, serial casting, splinting, or surgical release is needed. If the patient has myasthenia gravis or any neuromuscular junction disorder, Botox contraindicated because that condition already affects neuromuscular transmission. An active infection at the injection site is also a reason to avoid it. And if the patient or caregiver isn't ready for rehab compliance, it's important to set expectations, because without exercise the full benefit of Botox won't be realized. One more clinical pearl that experts highlight: the accuracy of injection placement is very critical. Muscle injection should always be guided by ultrasound, EMG, or electrical stimulation, so the toxin reaches the exact target muscle without affecting surrounding muscles. And clinicians should clearly tell patients that spasticity can improve, but it won't be cured. Setting this expectation is an essential part of the treatment, which reduces dropout rates. That specialists discuss after Botox, contractures and stiffness are reduced for only about 6 weeks, and after that they start to worsen again. So, how you should dosing cycles be managed over the long term, maintain optimal outcomes? The solution is, at every follow up visit, evaluate the patient's response, and based on the adjust future doses and target muscles. To conclude, Botox is a scientifically proven gold standard tool in a post stroke management, but it's not an isolated injection, it's an opportunity window. This window only gives meaningful results when it's combined with intensive structured task specific rehabilitation, stretching, strengthening, splinting, task practice, right candidate selection, right dosing, right muscle targeting, and most importantly the right combination with therapy. All of these together determine whether a stroke survivor regains their independence or not. Okay, so if you are a healthcare professional, it's important to understand that this field is rapidly evolving. New formulations, higher doses, protocols, and combination therapies are being researched continuously. And if you are a caregiver or patient, the most important takeaway is this: the decision about Botox should be made with a qualified neurorehabilitation specialist who looks at your specific spasticity pattern, functional goals, and overall recovery stage to create a personalized plan also according to that. Thank you.